Hello and marhaba, you're listening to Medical Protection Podcast Real World Series. I'm your host, Ceylan Simsek, and today I'll be joined once more by Dr Stephen Priestley, who's a familiar voice and will be hosting the Headliner series. Stephen, could you introduce yourself to our listeners?
Well, Ceylan, thanks so much for inviting me along today. I'm a senior medical educator with the Cognitive Institute and an actively practicing emergency specialist. And I teach clinical reasoning also for a university, Griffith University here in Australia. So I've been really pleased to be part of this diagnostic error and diagnostic safety series that we're doing. Thank you.
Stephen will be co-hosting alongside myself today, and today we have a very special guest, Dr Silvia Mamede. Dr Mamede, how would you like to introduce yourself to our listeners?
Hello, everyone. Hello, Stephen. Thank you for having me here today. My name is Silvia Mamede. I'm a physician by training. I specialize in public health. I'm originally from Brazil and moved to the Netherlands many years ago to work with research in clinical reasoning, medical education. I'm now an associate professor at the Institute of Medical Education Research, Rotterdam, the Erasmus Medical Center at the Erasmus University, Rotterdam.
Thank you, and thank you so much for joining us today. So, Silvia, could you start by sharing your story about how you became a researcher in the clinical decision-making and diagnostic errors area?
Well, mine is not a common trajectory in the field. My colleagues came from a different path. It can be even an example of how chance encounters and decisions we made in face of the opportunities that come to us may lead us down a path we never anticipated. As I told you, I was a physician, a public health physician. I became the dean of the School of Public Health in my region. And then in Brazil, a very poor region of the country. And I started to become more and more interested in how we could improve a physician's performance. I started to study experiential learning, how reflection upon our own experience could lead us to improve our praxis. And at the time we contacted Henk Schmidt, who was at the time a very big name in the field of medical education and problem-based learning. Henk introduced me to research on clinical reasoning. And I became more and more fascinated by the study of how our brain works, how diagnostic reasoning was possibly the most extraordinary example of the wonders and the pitfalls of our minds, and moved to the field. So it was a career change many years ago, but I'm happy with it, I have to tell you. I still find it fascinating.
That sounds like a really fascinating background as well. And it sounds like the opportunity with Hank was a turning point. So I'd just like to move on to the literature that we have. And the literature in this area tells us that a majority of diagnostic errors come from deficiencies in clinical reasoning relating to gathering and interpreting information. In fact, the way that doctors think when they are forming a diagnosis. Can you give us an overview of the current thinkings about how doctors think?
The early research in clinical reasoning, already in the first studies in the 70s, what it showed initially was that doctors basically use what we call a hypothetical deductive model. They generate diagnostic hypotheses usually very early in the clinical encounter, and then subsequently they test these hypotheses by asking more data from the patient, by collecting information from the physical examination or ordering tests. And the hypothetical deductive model is very consistent what became later on, subsequently, very influential in the medical literature. And it's the idea that we all reason through what we call two different reasoning modes. It's called the dual process models of thinking. And I think a very famous is Kahneman's book, Thinking Fast and Slow, that popularized the dual process thinking. And although there are different dual process theories, the common idea, the basic idea is that thinking involves two different processes, sometimes called type 1 and type 2. The faster system, type 1, is largely automatic, occurs largely unconsciously, apparently without much effort. And the slower system, type 2, is more controlled, more conscious, effortful, and sometimes this is called intuitive reasoning and reflective or analytical reasoning. And this model seems to tap very well, to map very well the hypothetical deductive model, whereas type 1 process or system 1 process is involved in the generation of hypotheses. We physicians move to the type 2 process to confirm the diagnosis or refute the diagnosis, for the verification of the diagnosis. Of course, this is let's say a simple way, a schematic way of defining how physicians reason. We know that both system 1 and system 2, both types of process, are usually involved in any diagnostic process.
And just for our listeners, because there's a lot of information in there, how would type 1 and type 2 be acted out in a clinical setting?
If Stephen can also talk about this well. If you see a patient, and then in the first minutes of the encounter, cues in the patient history tend to activate from the physician's memory, from the physician's long-term memory, what we call an illness script, a script of a disease. And these scripts can have different formats. They can be even an example of a patient seen before, but they can be also prototypes of a particular disease. The activation is usually triggered by some salient cues in the history of the patient, or the chief complaint, or even the appearance of the patient. And then after this hypothesis comes to mind, the physician tries to get more information from the patient to basically match the case at hand, the patient at hand, with the values that are present in the illness script that the physician activated from memory. This is why we say that the more scripts a physician has in memory, and the more organized, the more refined, the richer are these scripts, the better is the chance that the physician recognizes the patient in front of them as the disease that he has seen before, or that he has in memory.
So I'm happy to comment on that, because as an emergency specialist, I do believe I spend a lot of time in type 1 thinking and in pattern recognition, having been in emergency medicine for 35 years. I like to think I have built up a number of illness scripts over the years. And in fact, when a junior doctor might come and talk to me about a patient, I won't always get a recognition of what the likely diagnosis is, but I'll often then go and see the patient in the cubicle, and the contextual part, the age of the patient, the appearance of the patient, the pattern of symptoms, and any examination findings, just by doing that will often lead me down a particular diagnosis. The challenge, of course, in doing that, as Sylvia would know, is that you are prone to making errors at that time, and cognitive biases is one of those errors. The challenge is sometimes to know when to flip to a more reasoned analytical approach. When do you know that, gee, you're going a bit fast here? You're thinking you're recognizing all these patterns from your experience, but what is it about this patient that doesn't quite align to your pre-formed patterns? And when do you have to actually do a bit more type 2 work, which actually takes a lot more cognitive effort? That I think is sometimes the challenge.
Yeah, you might realize that this is indeed not a particular characteristic of physicians. It doesn't happen only to doctors. It happens to all of us in our daily lives. We make decisions, thousands of decisions every day, possibly. Basically by automatically associating what we see with the information that we have in mind. If I look at this chair, I am not analyzing the chair to see the characteristics of the chair to decide that this is a chair. I basically automatically associate what I'm seeing with an example of a prototype of that objective that I have in mind. And this usually works very well, but it's also, as Stephen said, it's very subject to error. If, for instance, a feature of a patient becomes very salient and tends to attract my attention, because, for instance, it's a clinical finding that's usually very much associated with a disease that seems reasonable at first glance, but indeed is irrelevant in the case of hands. And I stick to this first diagnosis and do not stay like what we call anchored to it, and do not go and verify more carefully the subsequent information that I can get from the patient. Or if a diagnosis comes very easily to our mind, what we call availability bias. A diagnosis comes very easy to the mind of the physician, because, for instance, he has seen many patients with that disease before. He's on shift on an emergency department and sees many patients with heart attack, for instance, myocardial infarction. And then comes a patient that looks like it, the myocardial infarction. The diagnosis of myocardial infarction will naturally comes more easily to the mind of the physician. But then he may miss a patient that has other condition that looks like myocardial infarction, but it's not. This is why we try to say, and you might realize that they putting all the blame in the type 1 process all the time is something that it doesn't fit with this model, because even if type 1 would, if a wrong diagnosis would have been made by type 1 processes, if type 2 process would work well, it would repair the initial diagnosis. So usually the two systems are involved, or mistakes can emerge from the two types of reasoning process.
And I do see that in my own work as well, where when I advise doctors or clinicians, what tends to happen is the patient comes in with symptoms, for example, of breathlessness after a traumatic incident. They have various symptoms similar to anxiety, and then that's what they diagnose the patient with, which then turn out to be heart failure. That's a very dramatic example, but it's the initial diagnosis of making a hypothesis because this patient had a traumatic incident. So immediately it could be anxiety, it could be depression, instead of maybe potentially exploring that a bit further. I do want to find out, is there a way to tackle this or reduce these errors that can be made as a result of human synthesis or faulty synthesis?
Yeah, there has been recently a lot of discussion about what could be seen as the side effect of the prominence that the dual processes theories have taken in the medical literature, and the side effect that starts to be pointed to in the literature is that we are so much concerned with how we can improve reasoning processes. We are so much concerned with understanding what are the sources of cognitive biases, what are the causes of diagnostic errors, that we have dedicated not so much attention to the search for effective strategies to deal with that. And there has been much effort in trying to develop sometimes educational strategies and workplace strategies. I like this distinction because I think the underlying mechanisms that would act in each case is different. But if we think about educational strategies, we are talking about things that we could do, interventions that we could do to help students or trainees or physicians to become able to solve new cases, new problems in the future, even when they don't have these instructions. Let's say they don't have this device, they don't have the assistance on how to do the diagnostic task, how to diagnose the patients. And the workplace interventions are more the interventions that you could give while the physicians that the physicians could have while solving the case. For instance, digital diagnostic support systems are now available in many workplaces, and the physicians could get help from the digital support system while solving the case. Or checklists. Checklists have been checklists. We were talking before about the disappointing results of what we could in terms of what we could do, but checklists have some look promising in terms of how they could help if checklists are focused on the content of the problem. For instance, there are many studies by Matthew Siebold, especially is the person who has studied more this type of checklists that help, for instance, in the physical examination of patients with cardiology related symptoms, or that helps interpretation of ECGs. These are things that are easily available, would be easily available to the physician at the moment of the diagnosis. And some of them have some promising. There are some promising findings from studies checking the effectiveness of these interventions. The other type of interventions is a little bit more, how could we say, doubtful. There have been many attempts to train physicians to the bias in educational interventions with courses or workshops that try to teach physicians or students what are cognitive biases, what types of biases may occur, what are the sources of diagnostic errors, and try to teach them how they could identify when they are under circumstances that could lead to mistakes. But the problem with these interventions until now, and this doesn't mean that better interventions couldn't be conceived, but what we have until now is that when these interventions, the effectiveness of these interventions was evaluated, what comes very clearly from them is that physicians or students become more able to identify bias. They in knowledge tests about what are the types of bias that exist, they are more able to answer these questions. But whenever they were asked to solve clinical cases, to diagnose cases, then there is no difference in terms of diagnostic accuracy. And much more promising in our view are interventions focused on basically refining the illness scripts that physicians have in mind. So educational interventions that focus on making physicians more knowledgeable about what are the features, the clinical features associated with each disease, what are critical diagnostic features that help discriminate between diseases that look alike. And when you do the results of this type of interventions, when they were studied in experimental studies yet, not in real settings, but when they were evaluated, this type of interventions help at preventing errors due to cognitive bias. We had a study we call, I don't know if you saw it, we call immunizing physicians against availability bias in reasoning. And it's basically an intervention, an educational intervention that 1 week before the test put physicians through problem solving and feedback to enhance the knowledge of features that discriminate between diseases. And this intervention was successful in making the physicians less vulnerable to availability bias when they solved cases, diagnostic cases, the clinical cases 1 week after the intervention. So I really think that, as in any other expert field, professional expertise field, knowledge is really a key. And it's not knowledge in general, but how the UNIS script is organized, how rich is the UNIS script that the physicians have in mind.
Silvia, the increasing knowledge required to be more accurate with diagnosis is certainly part of an educational intervention. What I'm hearing, though, is right at the bedside with the patient, we also need rapid access to that knowledge or organised knowledge that we can extract at various times. You know, we've obviously found that challenging over the years because our diagnostic error rate is running broadly at around 10%, despite what I'd like to think is an explosion of knowledge in our medical schools and in our healthcare facilities. What's the promise of digital solutions or artificial intelligence at the patient's bedside in order to be able to assist us in accessing large amounts of relevant information with the patient in front of us?
I think it's great. It's great. If you see digital support systems nowadays, even without starting to use ChatGPT or OpenAI as we are all doing, even without digital support systems that are based on a database of knowledge constructed by experts themselves before the explosion of machine learning and deep learning. Even these digital support systems can be helpful, and there are studies evaluating what is the reduction in error when you place physicians solving cases, clinical cases with and without a digital support system. The recent one that I saw was with Isabel. You probably know Isabel, Stephen, is a larger digital support system that's widely used also here in the Netherlands and in many countries. And the use of Isabel reduced the diagnostic errors in around 8% in this specific study, for instance. That's good because it's not the perception of the physicians that they do better, or it's a controlled experiment that can then really attribute the decrease in errors to the interventions, to the use of Isabel. And if you think this could have a substantial impact on the diagnostic accuracy, even if you think that 90% of the diagnoses are correct. If you would reduce the rate of errors in 8%, it could be a substantial gain, and it would be. I have been the last week trying with ChatGPT, for instance, and the response of this type of thing is really good. So it would be something available to everyone, and you could certainly help checking what are the findings that are, for instance, is this finding that's so atypical in this patient that I am suspecting of a brain tumor or pulmonary embolism, but this patient doesn't have a finding that I would expect here. But does this preclude this diagnosis, or is this present in an atypical? Of course, with all your experience, you have a range of representations of atypical variations of the diseases in your memory, and you can rely on it. But less experienced physicians or less knowledgeable physicians, for instance, that don't have this very rich illness script that contain all the possible variations of a certain disease, would benefit from a digital support system to check and say, oh, hey, this is still possible that this patient has pulmonary embolism, even if he doesn't have this thing that I expected that he would have. So I think this is really great.
Just for our listeners, Isabel is a form of digital decision support. It's really a differential diagnosis generator where you can put in the gender and the age of the patient and what area of the world they're in, and then a number of their different symptoms or signs, and it generates a large number of diagnoses, not all that need to be tested for that particular patient, but it's a useful checklist, as Sylvia was saying, to run through to say, have I missed something? Should I be thinking about this? So I must say, I've been telling our medical students and our juniors to use that. It's interesting that more senior doctors are far less inclined to use something like that software in order to augment their clinical reasoning, possibly because of experience, but possibly, I guess, because of unfamiliarity with those sorts of systems. I've always said that you're more likely to see atypical presentations of common diseases than typical presentations of rare diseases. So having a range of different illness scripts, if you like, for those common diseases that often present atypically is so
we
important.
Are trying just,
thank you for that.
Just a point about that, digital support systems. We have tested in many different experimental studies a procedure that we call deliberate reflection. And that's basically an approach that asks physicians to go back to the case after the initial diagnosis and try to look for information that denies the diagnosis, to look the information that confirms the diagnosis, and to consider alternative diagnosis, and go through this process of contrasting and comparing alternative diagnosis for the cases. In all the meta-analysis, the systematic reviews and meta-analysis that we saw, the deliberate reflection comes out as the most consistently successful approach to repair mistakes and to improve diagnostic accuracy. But it would be very rarely, very unlikely to be feasible to use this type of procedure as it is structured in the real clinical setting. And what we are trying to study now is how we could reformat a digital support system such as Isabel to replicate the basis of the deliberate reflection procedure, to work as if it would be, as if the physician would go through all steps of the deliberate reflection procedure. Because with the deliberate reflection procedure, the improvement in diagnostic accuracy goes up to around 40-50% in all the studies, depending on the complexity of the case, depending on the circumstances, if the physicians were subject to bias or not. But so the digital support systems, if the nature of the digital support system is aligned with this type of procedure that contrasts and compares different alternative diagnoses, maybe the efficiency of the digital support system can be made even higher. Instead of improving correcting 8-10%, they could correct diagnostic errors as this type of procedure, such as deliberate reflection, does experimentally. And this would be a great thing in real life, in real settings.
I think there was a lot of information in there that our listeners can take away, and it sounds like there is a lot of research being done in this. But just going along the tech route, with my members, the clinicians that I tend to advise, when there has been a claim made with a contributing factor of a diagnostic error, we tend to share with them educational resources. This can be in the form of fact sheets, webinars, or face-to-face workshops. And I can see that you've also done some area in this, Silvia. Using a malpractice claims database to drive aspects of clinical reasoning in training general practice. Can you tell us a bit more about this?
Yeah, well, I started my career in research on medical education by trying to study how reflection upon one's own experience would lead to learning. There is a famous educator that, in my view, is one of the greatest in the world ever, John Dewey from the US. And he has a say that he used it to say, we don't learn from experience. We learn from reflection upon experience. So I would tend to say that reflecting upon what has happened in a case that led to malpractice claims would have a great potential not only for the physicians directly involved with the mistake, but also for their peers. It's a real case. We try to conduct research by using vignettes that are prepared by our colleagues, internists or emergency physicians or general practitioners, based on a real life, but it's different from a real patient with all the troubles, all the stumbles that happened that led to a malpractice claim. We did a study trying to identify what were the most relevant malpractice claims that could be used for medical education here in the Netherlands. And this was trying to see, okay, where is it that our general practitioners are making mistakes? Where is it that what's going on wrongly? What are the most frequent situations? What are the most frequent circumstances? This by itself would be good, because then we can focus on these diseases in the training of the physicians. And I think there is much more to explore in this topic. I really think that using malpractice claims, preparing them for education, for instance, by making them anonymous, by trying to report correctly all the process that has led to mistakes, and making physicians reflecting upon that has a great potential. Even if the interventions that try to put physicians to teach physicians how to reason, the reasoning process, even if the results are not so promising at this point, at least teaching physicians what can go wrong, showing them that our cognition can be flawed. In the worst scenario, it would make us more humble and more motivated to learn and more motivated to improve. So I would say that this is a promising approach there, and we should pursue it.
I think that's a very good note to leave that final episode. And if there's one thing to take away for our listeners, it's reflection. That's deliberate reflection. So thank you so much for joining us, Silvia.
Thank you. Thank you all for having me here.
And also Stephen for co-hosting with me.
Thank you very much.
And with that, we've reached the end of today's podcast. If you would like a certificate for listening to go towards your CPD, or to learn more about what we covered today and who you were listening to, please do take a look in the podcast description. This is the last podcast for our Real World series, but tune in next week for when we hear more from Dr. Stephen Priestley and guests with his headliner series. I've been your host, Ceylan Simsek.